Oloo, who's going to talk about a public health intervention to improve the quality of the informal daycare centers for better child health and development in informal settlements in Nairobi, Kenya. So Linda, welcome.
Thank you, Anna. It's Anna, not Hannah. Thank you. Good afternoon, everyone. Hello. Hola. My name is Linda Oloo, and I come from Nairobi, Kenya. I work with the African Population and Health Research Center, which is a Pan-African research organization that conducts evidence-based research in Africa. So today I'm here, I'm very pleased to be here in Spain to talk about the findings of our work, which is improving the quality of childcare centers in Nairobi, informal settlements, through supportive assessment and communities of practice. So we did this using existing government structures. So I have to point. It's not moving. I need to point at him. Here. No, he told me to point. Okay, that's him, I think. I can move the keyboard. Should I move? Oh, they say no. Okay. It's okay. It's still not moving. It's moving. Okay. Okay. Thank you. Gracias. So just to give you a background. Sorry about that. So please move one slide behind. That's slide one. There, that's there. Okay, so informal childcare centers have come up in urban informal settlements, what we call slums. This is because, as we heard in the morning, there's a growing number of people moving into urban areas. And with this growth comes different aspects and challenges, one of which is that women are increasingly getting into paid work. And in urban areas, we know that we don't have kinship support, we don't have extended family to support with childcare. And to meet this demand, there have been so many daycare centers that come up in informal settlements so that they can fill in the gap and provide childcare services for these women as they go to work. One of the challenges we find is that these facilities are way below standard because women start them within their rooms where they live. And so you find it is one single room, and part of it is where she lives with her family, and part of it is where she takes care of the children. And so our aim was to co-design and test the feasibility of a model, which we call the communities of practice model, so that we could train community health workers for them to provide supportive assessment and to build skills in order to improve the quality of childcare in slums. So we had 4 objectives. The first one was to map and profile the quality of care in 2 slum settings in Nairobi. The second objective was to co-design a supportive supervision and a skill building intervention that could sustainably deliver within the existing systems. The third one was to assess in what ways this intervention can improve the skills of the daycare providers. And the last one was to identify facilitators and barriers that are facing childcare providers in these settings. So our method, we used a sequential mixed methods where we mapped all childcare centers in these study areas, the 2 study areas. And then we did a profiling of the quality, skills, and practices, after which we did a series of workshops with the different stakeholders running from the ground going up. And then we did an assessment of the environment so that we could know the knowledge and practices before the intervention and after the intervention. And finally, we did qualitative interviews with officials from the government, and we reviewed existing childcare policies. So the findings from the baseline data showed that these daycare centers that exist at home, the ones I mentioned that are started at the home area, the providers had very limited training, and parents were concerned about the safety, the hygiene, the nutrition, and the attitude of these providers. Yet they didn't have an option at all, so they had to leave their children in these centers anyway. There was also a lack of resources, lack of play materials, and lack of skills in terms of communication with parents, because you realize that these are very low income settings and the providers have very minimal education. So it's really lack of skills. And then the community health volunteers that we trained expressed a high motivation to deliver this intervention. And finally, the baseline findings showed that there's a need to focus more on learning through play, health, nutrition, child protection, and business skills for the center providers. Next slide. It's moved. Okay. So maybe I can just show you how we did the implementation of the intervention. We started by training the community health volunteers. We set out to train them on 4 skill models. So we trained them on the first session, which was on skills for learning through play. So after training them, they went ahead and trained the daycare providers in groups of 5 or 6. And these trainings were done within the environment where these people live, within the slums. So after doing the training, the community health volunteers again went and did a visit of the childcare centers just to see how the impact of the training was being implemented in the daycare centers. So we did this for the first session, the second, the third, and the 4th. So in total, we had a total of 4 modules that we trained the community health volunteers on, and which they went ahead and trained the childcare providers on. So in terms of feasibility and potential effects of this model, we found that the intervention was feasible and it was highly accepted. We successfully trained 20 community health volunteers, and they were able to deliver the intervention to 68 daycare center providers from the 2 slums. And in total, we had 52 sessions where the community health volunteers visited the centers just to see the impact of the intervention. And we had 136 successful visits in total to the childcare centers. So we have down here the indicators of the effect, which shows that there was a significant improvement in the knowledge and practices of the childcare providers. And there was also a significant improvement in quality of childcare centers after the intervention. So in terms of policy implications, we found that there's need to support informal childcare centers because, like I mentioned, the demand is very high due to the nature of urbanization. And it is important to integrate such kind of interventions into existing structures and systems so that they can be sustained even after funding ends and projects end. And In terms of partnership with government, we are still working with the government and other stakeholders so that we can be able to scale up this intervention across the country for it to be for posterity. One of the challenges that we found was the issue of licensing for these informal daycare centers. Because of the nature of these daycare centers, they have challenges of regulation, they have challenges of registration, licensing, and financing. So these are some of the challenges that we are pushing forward with policymakers so that we can have sustainable ways to support these informal daycare centers. Because if we say that we standardize registration, for example, most of these daycare owners are people with limited education, and you cannot expect them, for example, to have skills like other people who have a higher level of education. So we are looking at discussion on equity so that we can be able to support them to have such kind of skills and resources for them to be able to sustain this service. Finally, the next steps, I've already mentioned discussions on integration. We have developed a manual. We were able to develop a training manual that can be used to scale up this intervention. It can also be used in other parts. So if you are interested in this kind of a model, we can have a discussion so that we can share notes on how we were able to develop such a model. I've mentioned the implementation to scale. We are looking at the possibilities of scaling up this model. We are also looking at how the community health volunteers can be able to monitor the effectiveness of this model alongside the work that they do on a routine basis so that we are able to incorporate this on their day-to-day work. And then finally, the issue of licensing, like we have mentioned, we are currently having discussion to have the registration process for these informal daycare centers so that we can help to improve the quality of services that they give to young children. So thank you very much for your attention. I have listed there the research team. Thanks.
Thank you so much, Linda, for really great research project and for, I mean, I've been fascinated how you were able to, scale it up and doing 20 daycare centers, and kind of the toolkit all aligns with a lot of other work that the other presenters are doing today. And thank you for staying on time. And with that, I'm very excited to invite Jia-Yu Wong, who's going to tell us about how well the School Zone Sidewalk project helps to deliver a child walking friendly environment based on a case study in Taipei, Taiwan. Just wait for them. Just wait 2 seconds. Well, as we upload the presentation, maybe there are any questions to Linda? Maybe you can. Shall I just say that. That's really fascinating presentation, and we're working with IUD and informal settlement as part of your and you presented through the lens of health, but of course you could have presented through the lens of women's empowerment as well, given that the childcare facilitates women's working and their ability to move in different ways unencumbered by children. So I wondered if you had any thoughts on that, and whether you can sort of engage in the ministry agenda as well. It seems like it's a good leverage point.
Thanks for the question. I have my boss, the PI for the project here, so she will guide me. But for this project, our main objective was to test the feasibility of the community of practice model in terms of improving the quality of daycare centers. So I think that is one of the recommendations for future studies, And I think we are in discussion to look at other projects. There's one project we are doing, although it's an evaluation project, that looks at the women economic empowerment and the quality of childcare. Yeah. So maybe we can have discussions about the findings and and the variables. Yeah, thanks.
Is the mic? Oh, the mic is on. Hello, everyone. Gordana Rodic from Macedonia speaking. Thanks for the presentation. I was just wondering about the daycare centers, whether they were established by NGOs as informal education centers, or it were private companies, and whether it was something supported by the state, like some law that opened the possibilities for people to open the centers. Thank you.
Okay, so most of the daycare centers in Nairobi, in Kenya, in most of the slums are informal in the sense that a provider, mostly a woman, decides to start daycare services based on the need. For example, her neighbor would want to go to work, but she may not have someone to take care of her child. So she would take that child, and before you know it, she has 10, 15, or 20 children under her care. But the challenge is that the living arrangement, the dwelling units are single-roomed units. Most of them are tinned wall structures or mud wall structures. And so they are in deplorable, if I may use that word, deplorable conditions. And so majority of the daycare centers that we mapped for this study were those kind of home-based daycare centers. Although we had other types of daycare centers, like those who are linked to schools. For example, a primary school would have a daycare center within its facility. We would also have some daycare centers that were owned by religious organizations, and others that were standalone daycare centers, what we call center-based facilities. But looking at the quality and the need for this intervention, we did not include some of these daycare centers because we felt that they had capacity and they had a lot of facilities and skills and training. So most of the daycare centers that we included in the intervention were those that were home-based daycare centers. But maybe I could just mention that there is no support from government or NGOs because the law in Kenya, the national government states that learning starts at age 4. So they do not really recognize that there's need for support for children who are under 4 years. Thanks.
Thank you, Linda. And maybe later we can exchange some information after the workshop. Thanks.
Good afternoon, ladies and gentlemen. My name is Wong Jia-Yu. I'm the graduate student from Department of Urban Planning, National Cheng Kung University. Today, I'm going to introduce my research with you. My topic is how will the school zone sidewalk project help to deliver a child walking friendly environment based on a case study in Taiwan. First, during after school time in Taiwan, we can see many motorcycles riders getting on the sidewalk in these two pictures. This is a unique style in Taiwan. And why does this happen? The major reason is that the traffic conditions in Taiwan are risky. The left side and middle picture show that the sidewalk occupied by cars. Due to this, pedestrians be forced to walk on the road. So parents pick up their children in order to reduce the risk. But in Asia, Japanese students have started walking to school since elementary school. It is a commonplace in Japan. However, in Taiwan, it is unusual. How can we achieve more safety environment for children? This is the reason that I choose this topic to to share with you. Second, about my research background is Taiwan has the low fertility rate in the world in recent years. To meet the needs of society, setup of the environment is friendly to children is important. Taiwan has promoted an aging-friendly city, but the problem of the fertility is also necessary. We have to ensure their safety and independent activities. And next, there are two main knowledge to this topic: the child-friendly and the safe routes to school. The United Nations Children's Fund defines a child-friendly city as a city, a town, or a community that can improve the lives of children. And child-friendly environment definition in simple terms is a space where children are safe and able to move independently. The reason for advocating the importance of children's environment can be divided into two main points. The first is that children are easily restricted in expressing their opinions. Furthermore, in terms of physiological condition, because children's sense and physical development are immature, they do not have sufficient awareness of traffic condition. And because of their body shape, they are easy to be neglected on the road. Another one, safe roads to school, is an intervention designed to create safe, convenient, and fun cycling and walking for children. The term safe routes to school can be traced to 1970s in Denmark and follow up in 1980s until 1990s. These concepts spread to the United Kingdom, Canada, and so on. The study area is Taipei, Taiwan, where I come from. Let's look at the geographical location of Taiwan. It's an island in the north of the Philippines and southwest of Japan. These two pictures are famous landmark Taipei 101 and the street scenes of Taipei. The reason why this study area was chosen is that Taipei mass transportation is well developed. Overall, walking environment is mature, and Taipei school zone sidewalk planning is relative large scale and planned. School zone sidewalk is a similar compared to safe routes to school, but the school zone sidewalk project is lack of a national plan. That is also why I choose Taipei for study area better. About the effectiveness about the SRTS. In Odense, Denmark, this project successfully reduced the number of deaths of children on the way to school, helping to reduce children's pedestrian and bicycle collisions by 82%. And in New York City, US, implementing an SRTS program has helped significantly reduce school-age student pedestrian injuries. So out of my curiosity, how much effect will it make in Taiwan? Regarding the map field, I use the secondary data analysis. I choose 4 indicators: age, 6 to 15 population rate, and average individual income, accident density, and school density. So I choose these 4 indicators to check the school zone sidewalk implement site selection is in demand or not. At the end is the preliminary result and discussion. The school zone sidewalk is for school-age students, so we first look at the proportion of school-age children distribution. And I also wonder whether people with high income status have adequate economic condition to raise children. The correlation coefficient between two is about 0.47. They have a weak correlation, but there are still some areas that the proportion of school-age children is high, but the low income. Among the study area, there are 6 villages with such condition. Then I check if the school zone sidewalk location is related to the density of school. There are 8 villages with the top 10 of school density, but no school zone sidewalk implement. Simply examine if there is a difference between the condition within and without using the school SDS, the correlation coefficient between the two one is minus 0.02. They can be said to be unrelated. So therefore, we will conduct further research in follow-up study. So to sum up, the SDS policy to be established to evaluate the priority of implement. And besides the following study, it is to evaluate school zone sidewalk projects effectiveness in different ways. And this is my end of my oral presentation. And thank my graduate classmates to go to spend together. And thank you all for your attention. It was a pleasure being here today. Thank you.
So I know in the conclusion you said that like a different approach evaluating the sidewalk project needs to be done. Do you have any kind of thoughts or suggestions like through this research what it could be? That could be, and I know you use like GIS to tabulate the data, which is quite impressive that it does exist, because in lots of places around the world, people will be like super lucky to have this level of data. Yeah, maybe you can share your thoughts, like what's missing in the indicators to for the next steps of your research.
Maybe we can discuss it later. Okay,
That's good.
thank
Okay,
you.
no worries. Thank you. Okay, and I'm excited to invite our next speaker, Amanda Fernandes, and she's going to tell us about the primary school-based interventions to support a healthy, natural, and urban environments for children. Thank you.
So hi, everyone. Let's see. Yeah, it's going well. So perfect. Hi, everyone. I am Amanda. I'm a researcher at IS Global in Barcelona. And I am glad to be here to share with you the results of our systematic review. Just let you know that I should skip some methodological slides just for the sake of the time, but probably you already know more or less how you conduct systematic reviews, and you follow the standard protocol, and you can discuss it further just to let you know. So basically this review is related to our work at ES Global, because you want to protect and promote child's health, and you asking what is the best intervention to promote, school-based interventions to promote health, but taking different exposures and different outcomes at times. So it's a broad review, and and here speaker statement. So straight to it is our population. This review was primary school children aged 5 to 12 years, study in primary schools from urban areas in whole Europe, and also in high-income countries in the rest of the world. And basically, we select interventions that involve temporary or permanent change on the beauty environment and natural environment of the schools, with a specific goal to improve air quality indoor or around schools, especially hot traffic air pollutants, to reduce hot traffic noise, aircraft or automobiles, and also to increase exposure of children to green space during school hours. And finally, also our interventions that focus on increased active travel to school. That's mean walking, biking, as young Jia-Yu told us early in the session. So this is our intervention selection, eligibility, and then we included all quantitative studies. Doesn't matter the duration of the intervention, but they should be published in English, and you cover the last 11 years and the literature. And also we include all studies with or without a control group. So quite broad approach. And in the end, also we included as outcome any health outcome related to cardiometabolic, neurodevelopment, or respiratory outcomes, but also physical activity and active travel, of course, and also change in the exposure levels, because sometimes you have studies that measure this difference. So if their exposure to air pollutants decrease, for instance, so we include all this. So to extract data, so we follow the standard systematic review steps with double check, extraction, and screening extraction data. And you use this template, TIDER template, to describe each intervention detail. So our paper could be useful also to replicate these interventions we included in future research. And notably here, we're interested to see one of the questions of the template is about if the intervention design was implemented as planned. So this is a quick question, so keep it in mind, because you talk more. I will talk more later in this presentation. For the quality assessment, we use a validate tool with 11 questions that basically measure internal and external validity of each study. So we sum up the points of each question, and you define here a high quality study, those that score 9 or more in this checklist. So here now I give you a snapshot of each of the interventions you found. So we included 40 studies from 32 interventions, and you didn't find any intervention to reduce hot traffic noise around schools. So we have 10 that focus on air pollution. So they include a small sample size, usually a few classrooms, and all then focus on change the ventilation system of the schools. So basically they just build new ventilation systems to test in some classrooms and to see most of the time if they could increase the ventilation rates inside of the classrooms and consequently reduce the concentration of air pollutants indoor. So basically they measure, the main outcome here was indirect measures of changes in the exposure levels of air pollutants, and only 4 studies evaluated the impact of the intervention on health outcomes. Usually they are super short, 3 to 8 weeks, the duration of the intervention, and the quality was the range of the quality score from 6 to 9, with only 3 defined as high quality. And here for green space, basically you found two main interventions for green space. One, try to increase green time, or the time children spend in green during school hours. So by implementing outdoor classrooms, for instance, most of them, in fact. And the other side, you have interventions greening the school. So planting trees, reshaping the schoolyards, or implementing gardens. All they focus on neurodevelopment outcomes, since for instance, working memory or attention, and also self-regulation and P-relation as main outcomes, but also physical activity measured by accelerometers in all the studies. So here you have more controlled studies, and longest studies too, with two of them, they have more than two. They have up to years in the intervention duration. Also, the quality is a bit better, but still have only 4 papers scored a high quality. Finally, you have active travel interventions that you see in the previous presentation, that basically we found the same type of intervention, safe routes to school, that usually includes behavior components like encouragement, walking day, but also changes in the built environment. And the most common one was sidewalk renovation or implementing, and also crosswalk improvements. So here you cannot see health outcomes. So they look at the difference before and after active travel proportional rates among the students, no? And but they were usually long studies, with some of them more than 3. Yeah, compared to the others, I think they are longer, 2 to 5 years or more than that. But again, just volume 1 scored with high quality, have a high quality score. So this is just the geographical distribution of that. Just take my lead here to not speak much. So you have more active travel interventions come from the North America, and what you expect, and more, you cannot see the map, sorry for that, but anyway, just imagine that. And from Europe, most common interventions were air pollution in green space. So here you can see it, right? Perfect. So this is just the intervention effects on the outcome. So if you look at here, for instance, for active travel, I color it in red all the positive effects of the intervention, the outcomes, and the length. So each slice is a study, and the length of the slice represents more or less the duration of the study. So for active travel, you see across different durations, you see a positive effect, even though have only one quality study in this group of interventions. For green space here, you see quite consistent effect on cognition with different studies, also coming from this 2E study I mentioned before. Quite similar also for physical activity, but not the pictures a bit inconsistent for self-regulation. And for air pollution, you see any effect for no effect for respiratory, heat, allergies, and asthma, coming from this change in the ventilation systems of these school buildings. And here also inconsistent effect for cognition. But it seems that they quite achieve to improve air quality indoor based on the pollutants and the measures they proceed. So yes, so just to sum up, you see that increasing ventilation rates improve short-term indoor air quality in classrooms, but inconsistent effects on cognition. Also, you saw that greening schools maybe increase physical activity, especially in girls. So this increases around 40 minutes a day. And also that more school time in nature may improve working memory and attention in both sexes, but the effects on self-regulation are inconsistent. Multiple component interventions come for active travel can increase walk and cycling after 1 year, but again, the effect was small. So around 5 to 10%, and also it was inconsistent over time. Even though one controlled 4-year study you have, including this review, stated they compare different types of interventions. They saw that only encouragement without urban change decrease active travel after 4 years in the intervention implementation. So just to finalize, I just have some takeaway message for researchers. I think the main first, hot traffic noise is a gap. It's important to also think about the costs of these interventions, especially when you talk about air pollution interventions involving change in the school building, but also the burden on teachers and school and students. But the main message, I think, is please, for the sake of the replication and good science, inform on the adherence and fidelity of the intervention. So if the intervention was planned as designed, if not, why? I know when you're doing real world research or intervention, you know, in the real world in urban health is quite complicated to keep track on all that. But at least in the limitations section of the paper, you need to set out, you could not measure adherence or fidelity. And another important thing is maybe a misevaluation opportunity in terms of co-exposures of our interventions, because I think it's really cool to improve the number of children walking to school. But if this intervention also at the same time improves children's exposures to air pollutants, I think you need to think it again. So it's a challenge that you think about. And for policymakers, I don't know if they are here. I mean, we are all policymakers at some point, but yes. The main message is, I mean, you need action because all the studies reporting air pollution interventions, they stated that you have unacceptable levels of air pollutant inside classrooms. So you need action. And maybe the way to think together about it is to have co-design interventions, participatory interventions, using a more holistic multiple intervention strategies approach, right? So I think that is the main message here. So please, you need to put more policies on that, and you need to invite the researchers to participate in the process from the beginning too. So I stop here. Thank you so much for all the involved in this research. One of this is here, Mònica. Thank you also to Nadia and Gonzalo.
Any questions, Amanda?
Did you check on the years? Because I guess for ventilation in the classrooms, before and after COVID, there was a huge change. Indeed. At least like in Germany, they implemented a policy of ventilating the classrooms every half an hour to 45 minutes.
Yeah.
So I would be interested in seeing if any more or less, or if they change the interventions on the air pollution.
Based on COVID, or
yes,
okay,
yeah, because that was
the air pollution studies, eligible air pollution interventions found, they were quite old, to be honest. So it was before COVID, but this is a quite interesting point to include in our discussion too, because I was a bit frustrated to see that you cannot include it more, you know, holistic big interventions around school, that you focus, come on, you're going there to really build new devices to test in one classroom, stay there like for a few hours, and then for me, it seems quite limited, but this is a good point. Maybe for COVID, it was an important change. But in that case, you didn't see any mention, probably because of the publication year too. Yeah.
Also for like activities outdoors.
Uh-huh.
Especially
Yeah, I mean, there we have like the last paper published was this year. We have many papers published this year, but they didn't mention baby because the process was like, maybe if you should look at the literature now, or maybe now next year you could find it. But that's a good point for the discussion of paper. Thank you for raising that. Thank you.
Okay, and I'm happy to invite our fourth speaker, Dhananjay Bansod, who's going to tell us about understanding the effect of social capital on the depression among adolescents in urban India.
Thank you. I'm Dhananjay Bansod. Sorry. I'm Dhananjay Bansod, working in the International Institute for Population Sciences, and this is my student's paper. Actually, she could not able to attend this, so I'm presenting her paper. Okay. Yeah. The title of the paper is Understanding the Effect of Social Capital on the Depression Among Adolescents in Urban Health. And this is, as I said, this is my student's one. Okay, so social capital. Now we are discussing about the social capital. Social capital refers to the connections amongst individuals in social networks and the norms of reciprocity and trustworthiness that arises from them. And these are the different concepts of the social capital that we have seen here. The social capital is the useful and the productive aspects we gain through social activities and bond with others. So here we are looking at the social capitals through the sense of belonging, diversity, values, norms, or the outlook in life, the citizens' power, proactivity, participation, reciprocity, feelings of trust and safety, and lastly, the networks, that is bonding and the beginning. Okay, so as the adolescence is the period of human growth and development that occurs after childhood and before the childhood from 10 to 19 years. Here we are taking the age group of 10 to 19 years. During this period, an adolescent acquires physical, emotional, cognitive, social, and economic resources through various forms of social capital that are the foundation of their overall health and the well-being. However, the social capital is a neglected determinant of mental health in low and middle income countries, including India. That's everywhere we're looking at the social capital or the mental health. But when you talked about the adolescents, that we are missing out, means there are not much study on this mental health of the adolescents. So that's what we are planning to conduct this one. Further, the mental health is a really global health priority, particularly for children and adolescents. As we already said, that we are not mainly concerned about the mental health on adolescent or the children. So that's what this is the thing that we wanted to study. The notions of mental health needs to be understood, especially when its assessment is done within the context of social capital. Therefore, this study intends to examine the effect of various forms of social capital, that is family, neighborhood, and social, on mental health, that is a depression among urban school-going adolescents in India. So this study is mainly based on the school-going children, and we are taking the students from 8th standard to the 12th standard. Okay, so from where we have collected the information, so that is the studies based on the primary data. We have collected this information from the Varanasi city of Uttar Pradesh, and that is we have selected these samples from the purposively, and you can see that 24% of the Varanasi's population comprises of adolescents, that is 10 to 19 years, and out of which the share of adolescent girls is 11%. The adolescent can be divided into 3 various groups based on their age, that is the early adolescent, 10 to 12 years, middle, and the late adolescent, But for these studies, we are concentrating on the middle and the late adolescents. The study conducted on school-going girls, that is 8th standard to the 12th standard of 13 to 19 years of age. So that's based on the school studies. Okay, these are the sampling frame that we have used to get our samples. So that's the one Varanasi city, having the 5 zones, and these are the finds. So from each zones we have selected each one wards, and from each ward we have selected 2 schools, and from each schools we have selected 35 samples, means 35 girls, and that 35 girls comes from the 7 girls from each standard of their schools, like 8 to 12 standard. So altogether our sample size is about 350 adolescent girls. And selection of the respondents, as we already said, the systematically was selecting the samples, and complete list of the students was taken from the class teacher, that class attendance registers, and based on that we have selected. The aim and the procedure of the study explained before undertaking the study, because without the info, we cannot take the samples. We have consent and other things we have taken from the class teacher as well as from the students. The students completed the anonymous paper questionnaires in the classroom, with the researchers being present there itself, and the researchers helped students whenever they required, because there we have just explained the aims and the objectives of the study in front of the students in the classroom itself, and we have distributed the questionnaire, because this is based on the questionnaire, and we asked them to fill it up, and in case of any doubts or any things they were having, so we are there to answer their doubts or to clarify their doubts. And also we have collected some information from their mothers. The mothers of the selected students were also personally interviewed at their household, and we have gone back to their households and collected information from their mother. Okay, these are the survey instruments that we have used it for girls schedule. These are the different sections, and for mother schedules we have used these are the different sections. And now we'll see the findings. Here we can see the caste, the percentage of household by the caste. This is general profile of the things. So in our samples, about 50% of the sample come from the OBC caste groups, whereas around 20% belongs to the SC/ST populations, and around 77% belongs to the Hindu religions, where we can see the education level of the mothers as well as the father. We can see around 28% of the mothers are illiterate, or can say that they are not educated. Or when you see the fathers' educations, here we can see the 31% of the fathers are educated and with having the graduations and above level of educations. And when talk about the wealth quintiles, but here we cannot see any kind of differences, whether they are from poor or the rich. All these 3 categories belongs or the similar kind of things. And when you see the type of the family, you can see that 59% of the elderly, they belongs to the joint or the extended family. And the composition of the children, here we can see that daughter and 11% of the adolescents, they come from the daughters only family, where they have only daughters in the families, and the 19% we can say that there are more daughters than the son in their families. And when you talk about the mass media exposure, here you can see that 77% of the adolescents are having the mass media exposure, that is almost daily. Okay, now come to the depressions, the prevalence of depression among the adolescents. Here you can see that about 40% of the elderly is having some kind of depressive symptoms. And when you talk about the high depressions, you can see the 14% of the adolescents are having the high level of depressions. And the why they have this kind of level of depressions, when you talk about in qualitatively, so one of the girls said that in both my parents are working, and after reaching home from the schools, there is no one to take care of my needs. I also have to take care of my younger siblings. In the process, I sometimes feel neglected, and because of that things, they feel like neglected, and that affects their mental health. The prevalence of depression among adolescents by the level of social capital. Here we have looked at the social capital and the prevalence of depression, whether there have any kind of relationship between the social capital as well as the level of depression. So here we can see that as the social capital moves from low to the high, the prevalence, we can see that Okay, from low social capital to the low to the high, so where you can see that the prevalence of depression is going down. Okay, this is a very big table. I don't want to explain it now. And this is a logistic regression, ordered logistic regression. We use it, and here everywhere you can see that with the increase the level of social capital, we can see the reduce the level of depressions. I'm just keeping these slides and I'll just summarize these results. This study is very timely and significant in bringing the issues of depressions among the adolescents to the forefront. The study found that almost 14% of the adolescent girls reported high level of depressions, and the study clearly outlined the importance of social capital in declining the depression among adolescent girls. And the social capital, in combination with other background characteristics such as caste, wealth index, composition of children, type of family, mass media exposure, and parental education, plays a critical role in defining the depression among adolescent girls. The study found that an inverse relationship for depressions with the education status, where the increasing parental education status in combination with social capital reduces the risk of depression. Odds of depression was lower among OBCs and other caste girls than in SC/ST girls, and they further declined with the increase in the level of social capital. This suggests that the SC/ST girls are more prone to the depressions, and it needs some kind of intervention to improve their level of depressions. The household wealth index was another important factor, where rich girls were less likely to report depressions than the poor girls, and the odds decreased further with the increased level of social capital from low to high. And belonging to the rich households provide a sense of security and the better treatment that have an impact of the low level of depression among girls. The same can be said about the high education status of parents leads to lesser odds of the depression among the girls. Importantly, social capital was a critical factor in examining the depression among adolescent girls. The study even evidently noticed that a higher level of social capital was linked to lower odds of depression among adolescent girls. Higher social capital provides a safety net to adolescents and allows them to always find someone to discuss their issues to one or other persons. If they have someone, their friends, their family members, or someone neighbors where she can talk frequently, so that accordingly their level of depressions can be reduced. Now the policy recommendations. Here you can see the adolescent girls are quite preponderant towards the high risk of depressions. To address the problems more comprehensively, planned interventions directly targeting to the significant predictors would be beneficial. Additionally, parents must be made aware of their role as a preventive factor. And in addition, school teachers, parents, and the community health workers should be collaborate to identify depressive symptoms in the timely manner and seek appropriate treatment if needed. Also, the need of bringing the discussions related to social capital in policy discourse is very important in the current context. Thank you. Yeah, any clarifications or the questions?
Yeah, thank you. It was very interesting. I would like to hear how you measure depression, which indicators you use, because that was not clear. How you measure social capital, which indicators you use, and how you corrected for endogeneity.
What is the last one?
Endogeneity. Education is one indicator of social capital, so you cannot say that higher education, it means also higher social capital, because that is one of the measurements, as well as socioeconomic status. A higher socioeconomic status allows you to have higher social capital. Therefore, it's very difficult to say that there is a direct connection in that term, and the effect that it will have in the mental health status of the girls. I think that might be just misleading you if you don't control for it.
Yeah.
Thank you.
Yeah, your first question related to the depression. How do I measure the depressions? So to measure the depressions, we have used the KID screen 52, that scale, and with that we have measured this KID screen. And for social capital, we have taken the three considerations, like household, the schools, as well as the neighborhood. And based on that, we have calculated the social capita. Okay, we consider that a household, how many family members are there in the household, whether the parents are there, whether they're discussing with the children or not. That kind of issues we discuss in while collecting the information when we talked about the family capital or the household social capital. Talking about the neighborhood, so how many people are there around the areas, whether they are having any kind of relation with them, whether they're talking to these people, whether they're having the proper peers, friends and all, and that will have any impact on their health. That's the second one. And third is schools, school based, because the school environment is also important for their social capital. So all these three we combine together and put it together in a social capital. And your questions related to the whether the educations and wealth mental, how it affects the mental health. Because as you say that the environment, what is that, the educations, the parents' educations are more important, as we have already seen here. If the parents are educated, that will affect or that will reduce the level of depression among the adolescents. But similarly, if the parents are educated, and both the parents are working, highly educated and working, and they do not have any time for the children, so it inversely affects their mental health. So that is the one thing. And also wealth again comes through that one. So that way only we'll try to capture this. Thank you. Yeah, it's okay.
Thanks. Thank you for the presentation. I was wondering whether the research will be used to influence policymakers to do something concrete about the poor girls and how to include them or give them a sense of belonging or something like this.
I'm not sure whether we can influence, but at least as a researcher, we feel that these are the issues that we need to focus and see, like family members, or when you are having any kind of policies and you are including the family members, the parents, while having these kind of discussions, or in the schools, teachers, so that in that sense we can even talk to these people, so that the teachers will help their children in a proper way, so that whatever the problem they have, they can even discuss more with either with their parents or with their teachers, so that all these things they can speak it out, so that they can at least try to control or try to minimize their depressions if they have anything. If they do not have anyone to talk, so that they will keep everything inside and they may not come out, and finally they will have some kind of loneliness issues, and that it leads to the depression.
Thank you.
Yeah, thank you.
Okay, our final speaker, Mònica Ubalde Lopez, will tell us about environmental and health-related impacts of interventions in the primary public schools transformed into climate shelters in Barcelona, a pilot innovative study.
Thank you. Well, thanks so much for your introduction. Thank you for being here still. Last but not least presentation of the day. So I'm happy to share with you for the first time publicly the results of this study, of this program that has been deployed in Barcelona in the last 2.5 years. We had the closure event 2 weeks ago with the City Hall. So this is a pilot study. It's framed into the urban innovative actions of the European Commission. It was led by the Barcelona City Hall, and it's called Blue, Green, and Gray: Adapting Schools to Climate Change. And there were 10 schools in the city, it's one for each district. One extra school is because it was a partner, so one district had two schools participating as an intervention schools, and then we also select 10 control schools for the monitoring strategy design that I will explain later. So this project has the objectives to, through participatory and educative process, to transform these pilot schools into climate shelters, not only for the children and the teachers, but also and the families, so the community, the educational community, but also for the citizens, as a climate shelters open to the community for improving the thermal comfort and the environmental quality, especially during the heat waves, with these three legs intervention: vegetation, which is the green component, the water features, which is the blue, and adaptations to the building inside and also outside. And then the third main objective was to evaluate the impacts of these interventions, not only on the quality, but also on health-related outcomes, and for sure to identify which of these interventions or features have worked better to be replicable and then to scale up in the city in other programs. So, as I said, the objectives were specifically of the evaluation of the interventions were to assess the impact of these three alone or combined interventions in the schools for the environmental air quality, thermal comfort. We also assess a cognitive outcome, which was attention level in children, and also we assess the use of the schoolyard during the recess with systematic observation tools. And we look specifically on physical activity types and level and how children interact. And how we did this evaluation of the program of the intervention. So we follow, I'm not gonna go into detail, but this is how the feature of the monitoring strategy looks like. So you have the interventions in summer 2020, and we have a pre and post monitoring assessment in the intervention and control school, which were paired with the same criteria that were selected. And as you can see, we have here, you know, the impact of the COVID pandemic because the schools were closed. We have the more strict confinement in Spain, and in this case, all the, you know, public engagement and all the public connections were avoided and schools were closed. So all the pre-monitoring assessment, especially that part that involved people, so teachers, children, were canceled, but we only had the environmental piece ongoing with the continuous and specific campaigns to characterize the environmental quality, because we had access but restricted to schools, but not to evaluate the individuals because they were not there. But anyway, we had to adapt these tools and the indicators to the new situation, and then we were able to have this monitoring strategy at the end. So we use different tools from devices located in different points inside in the schoolyard, outside the school, and also in the classrooms with different low-cost sensors and also middle-cost sensors that were used also to validate and to control these low-cost sensors that we use for the continuous and the specific characterization at some point in the monitoring strategy. We also use NU2s for the environmental quality assessment. And then we use also devices for evaluating the individual exposure, in this case in teachers, of thermal comfort. So we measure individual exposure to temperature and relative humidity to calculate the thermal comfort they expose. And then we also ask them 1 week after with a questionnaire, their perceptions on thermal comfort. And also we use, this is the recording form for the systematic observation of the schoolyard used, and also validate test for the cognitive outcome, which is the flanker task test. And the question is, because we are in evaluation, monitoring, assessment, has the schoolyard improve with this adaptation to climate change? That was the objective of the project. So this is how the school, two of the examples of how the schoolyards look like before and after the implementation of the solutions, in this case, with especially green and gray solutions in the schoolyard, providing shade and more, you know, green and different grounds with different, you know, materials. And this is another one, another example of the school that changed completely from a basketball or a football yard to a more, more different kind of features to use the schoolyard. And then about the temperature. So were these features effective to reduce or to improve the exposure on temperature? So you can see here in this example, this is the schoolyard before the implementation, and here you have, the more hot areas in the schoolyard, and how with this mixed solution, this solution mixed green, blue, and gray features, with this gray one here, and with this green in the schoolyard, how this, in general, it seems like the measured temperature has improved, except for this solution that seems to be not effective to reduce temperature in this case, but to increase it. So I'm not gonna go into detail in this graph, but just it's very, it's very graphic. So this is the hot map for showing you how the gray interventions were effective on increasing or reducing the temperature. All the specific ones in the different schools. So this specific feature, and you can see in the gray, the more dark colors are significant changes, and then in red, increasing temperature, and in blue, decreasing temperature. So you can see here that gray interventions alone were like effective, some of them in some of the schools, to decrease some points of temperature. Then gray and blue. So this combination, some of the schools have a combination of green and blue, and you can see that we are getting like more effective features in decreasing temperature in the schoolyard. And finally, you can see here that the mix of the three green, blue, and gray features were the most effective at the end, because you can see here the heat map is more in dark blue. So significant reductions in temperature in the school just with this mixture changes. And when we look into the indoor temperature in the school, not in the schoolyard, you cannot see here very well the graph, but at the end is that this is the representation of the days, the mean days that the temperature indoors were over 26 degrees. And this is the representation of the mean temperature in the whole monitoring campaign. And in summary, in neither intervention and control schools, we have not improvement. Even we have increases in the days, in the mean of days with temperature over 26 degrees, sorry, and also in the mean temperatures, and also significant, especially in the intervention schools. So something in the general picture has not worked, but as you can see, when we evaluate feature by feature intervention separately, we found that some of them are actually efficient. Then, as I said, we measure also the individual exposure of a sample of teachers during the school schedule, and we calculate the thermal discomfort based on temperature and relative humidity during the school hours. And again, in the usual areas they spend time during the school day. And again, we have seen not improvement, but even an increase of this measured thermal discomfort. But when we ask in the questionnaire after the week of the measurement of the perceptions, then it seems that the proportion of teachers that they perceived the general temperature of the school, good or very good, slightly increased, and also compared to the control schools, even more. And then also the proportion of teachers also improved, that they feel that the temperature of the school is too high often. So it also decreased. So at some point, the perception, even though the objective measure have not improved, the subjective measures of the perception, which is at the end what counts, let's say, so has improved somehow. And then asking teachers about not only the thermal comfort, but the environmental quality of the school in general terms. So again, For the intervention group compared to the control group, they increased 11% the perception of teachers that said that they perceive good or very good the indoor environmental quality. And also, this is the highest impact. So they really appreciated, they really perceive very well the new plants and green areas in the schoolyard compared to the control schools. And then we asked also to children. This was another tool that we administrate together with the Barcelona Public Agency, which is one of the other stakeholders involved in the monitoring assessment. And children overall in the intervention schools, they really find better temperatures in the school. So they are less annoyed by high temperatures compared to control schools that have not changed after the intervention. And most of them, 7 out of 10 of the children really appreciate and they think that the school has been turned into climate shelter. And they say this is part of one of the qualitative piece that I'm not talking about here, but this is one of the sentences they say. So our day by day has improved by making it less hot and the playground is a better place. So one of the objectives, even though the objective measures set in general that seems not to work, but specific features work and the perceptions of children also change in positive way. And then we had not differences in the attention levels improvement in between intervention and control schools. So both improve. It was expected because they are growing up, their cognitive function, it's also improving, but we had not significant differences in between intervention and control schools. But I had to mention that you have seen this, mark in all the slides. So as I said in the monitoring assessment, we had a COVID thing here. So there is a natural intervention within our intervention that have affected results for sure, and we need to still chew all the results and to think more about it. And the last thing is, what about the use of the schoolyard? So as I said, the schools when reopened in September 2020, and then in the new course, they have a very strict protocols for the use of the indoor in the school for the children. They had to interact in bubble groups, little groups, they cannot mix, and also the use of the schoolyard was restricted. They have specific areas that were split differently every day. So this also affects this observation. But at the end, what we observed is that less girls were playing alone and more interacting with big groups and a mixed gender. And also about physical activity, what we have seen is that there was a diversification of the levels of physical activity. It seems that there is a decrease of vigorous, but what happened is that the types of physical activities that they are doing are more for interacting, working, playing more in groups, but not in vigorous activities like sports, but more kind of, you can read it here, like play chess or doing fantasy games or sandbox or other activities and moving without running because of sport, but because we are locomotion activities that they increase and they interact much more. So yes, to this take-home message from this evaluation of a pilot and innovation study is the need of evaluation. So it's not only to implement solutions, but to know about what is working and what is not. Also to use different methodologies that are complementary, different points of views, the stakeholders, the community. And there was something that also, Amanda, arise from our review. So the need of a long-term monitoring and evaluation is not only about implementing monitoring the assessment now and before and after, and that's it. So we need to look at the sustainability and the effectiveness in the long term, and then the adherence, and that there are other benefits, co-benefits beyond the objectives of the pilot. So the pilot was to test features and to see if they are working. But we got other benefits beyond the thermal comfort that are also important, and to have into account that the COVID context has impacted these indicators, and we need to think more about it to understand really the effects of the intervention. And that's it.
Thank you. It was a really interesting presentation, really interesting results. I was thinking, did you include any aspects of co-design and including the local community, teachers, children in selecting specific features or interventions or the design, or are you planning to do this even more involved in future projects? Because I think that these kinds of inputs from the local community and the actual users can improve the end results even further.
Yeah.
Thank you.
Thanks for the question. I really passed really quickly for that point, but it was in the first of the objectives of the pilot. It was the first objective was through a participative process and also pedagogical. So yeah, from the beginning, the community, teacher, children, and also different local stakeholders were invited, and they actually participate in the design of the kind of interventions that the school needs, and also those that could be implemented, because it was first a technical study on how the school was built, the installation and other more physical indicators, and then evidence-based. Also, we had a review on previous studies on green effects on benefits on health, gray and blue, and then based on that and their needs and also their wishes and managing expectations. This is one point also to have into account. So then the projects were drawn, and not with all the things that they would like to implement, but it was a participative process from the beginning. And then they follow pedagogical process through all the monitoring, assessment, and all the phases of the program. They have pedagogical sessions also were involved as a citizen science, also with the sensors looking at the data. They could draw projects with their science teachers to do studies or whatever. So yeah, thank you for the question.
I would be interested in a follow-up study, because also in Barcelona, I noticed that a lot of the green areas that are new, after a couple of months, people also realize that things can go both ways, like wrong and right. Like they look nice, but they can also attract rats, mosquito breeding sites. And
yeah.
I'm guessing that it needs a lot of engagement from the community, from the school to keep them up tidy, but it could also be as well as a harbor for biodiversity in the city. But then when it comes to treating mosquitoes, like now I also saw the problem with tiger mosquitoes or rats.
Yes,
and then how to
I will start with
that.
the tiger mosquito, but you know, with the lack of biodiversity we have in cities, and in Barcelona, where the city, as you well said, is boosting this more green city and biodiverse. We already have tiger mosquito without the biodiversity, so probably increasing the biodiversity will decrease this tiger mosquito, and because we will tackling with other climate change factors that are doing that the tiger mosquito is already here. And for the follow-up, yes, I would like to. But this was a pilot study, and this was the booster, has been the booster for the program that is now being deployed in the city. It's called, in English, is We Transform the Schoolyards. It's like greening the schoolyard, but not, it's not affecting the building, but more the schoolyard is like the follow-up of that. But there is no monitoring evaluation for this project. That yes, we tried to, but there were no funding, so the project finished last October. So yeah, it will be nice. That's what I said, that we need like longer evaluation strategies to confirm the effects on sustainable interventions. Thanks so much.
Thanks. I just have a general question. If there is someone here in the room who did research or can recommend documents such as strategies for street children, and if you have information, please share. And just a question to all of us, if you were a mayor and you had to create strategy for children's rights, what would you do first? Or what would you recommend for a strategy for children's rights in your city?
We have local elections in May in Spain, right? So I'm not gonna propose myself for a major. It's a very hard, work, but they will start with the mobility planning. So we start with mobility plan, and I think that we will tackle with many of the risk factors that are related to harmful for health that will be, solved or at least reduced. Yeah, that will be my strategy if I was a major, but it was not the case. It will be not the case. No. Thanks so much.
Well, thank you for all of our speakers. Thank you for the audience. Thank you for all of your questions. I also want to I think we had a few online attendees as well. So thank you all for listening. And just for your final remark, when I'm going to be a mayor, first, I agree with Mònica. I'm going to tackle mobility issues because unfortunately, each day 500 children die in road crashes globally. So it's a big number that we are unfortunately not urgently addressing. And I think with that would come like all of the other projects, and through all of your presentations, I think would be amazing to connect like the research on green schools and safe routes to schools and depression and daycare centers, and kind of like think holistically how we can connect all of that. So thank you all. We'll see you, and please connect with each other. I think like that's the biggest advantage of this in-person conference. Thank you.